More than 250,000 adults and children in Minnesota live with a mental illness. In the spring of 2016, Governor Mark Dayton established a task force on mental health to look for ways to improve mental health services across the state. Joining me is the Assistant Commissioner for the Department of Human Services, Claire Wilson, to talk about the recommendations of that task force. Welcome.
Thanks for having me.
This is a very complex problem, and it was interesting to me that there were meetings held throughout the state. So there was a lot of intentionality in that. Why was that important?
Really, moving around the state was critical, the task force felt, to really understanding the experience of Minnesotans across the state as they experience the mental health system. You know, if you have a heart attack in Rochester or you have a heart attack in Crookston, you're going to be treated essentially the same protocols are going to be followed. It's very different if you experience a mental health crisis. Your access to treatment may be different depending on where you are in the state. The protocols may be different. There's real variability by region. So it was important to the task force that they get out and really hear from people with lived experience across the state, as well as providers and counties and others who are delivering the services.
The first recommendation surrounds the continuum of care. What is happening today with the delivery of care for the mentally ill, and what needs to occur?
You know, right now we have a system that is really focused on the high end of the spectrum. So we've really invested a lot as a state in intensive interventions.
So people that are like really
really sick.
Okay.
People whose mental illness has not been addressed early enough to prevent them from ending up in a mental health bed rather than a jail cell. So really looking at the continuum means thinking about how do we invest in promotion and prevention of mental wellness? How do we really think about transitions between levels of care? So when you're discharged from treatment, what does it look like for community supports? How do we build up community supports? And how do we ensure that we're really creating a system that intervenes from early onset into resiliency and recovery?
There's increasing understanding of the role that trauma plays in mental illness, most publicly with soldiers returning with symptoms of PTSD. But it isn't just soldiers, it's refugees and it's people from cultural groups that have experienced trauma. One of the recommendations talks about a cultural lens to reduce mental health disparities. So how does that work?
I'm really glad you framed that question that way, because the task force did hear from many communities of color and refugee communities that the impact of trauma on their experience is profound. And the system as it's currently developed has not necessarily addressed those experiences in a way that's been culturally proficient. So this is Minnesota. Our demographics are changing drastically, and we need cultural providers. We need treatments that are responsive to the needs of the ways certain communities experience and even define mental health or mental illness. And so really the task force prioritized ensuring that our system continues to be culturally responsive and is built on some of those principles.
And how would that work? Is it more training for those working in the field to understand the cultural background of the people they're working with?
It's both recruiting and training current providers, as well as expanding that workforce to include providers who look like the communities they're serving. It's creating more opportunities for people with lived experience to engage in the system as peer support workers, as community health workers or cultural liaisons. And then it's also just looking at different barriers in the system that create more challenges for communities of color to access treatment. So longer diagnostic assessment times, or not enough of a sustainable rate structure for culturally specific providers to survive. So it's various ways of looking at it.
One other aspect, the death of Prince highlighted the epidemic of opioid abuse in Minnesota. There are those, it's not just the opioid epidemic though, it's also alcohol addiction. And so regardless of the type of addiction, it pervades all levels of society. So how do we work towards parity in treating that? Treatment is very expensive for addiction.
That's right. You know, the task force recognized that you really can't talk about mental health without talking about chemical health, that there's such a high frequency of co-occurring. And the task force also really looked at parity and ensuring that treatments are covered by both private insurance and public insurance, and that there's parity in the ways that those are both paid for and accessed. So there were strong recommendations that the Department of Commerce look at network adequacy and look at what's currently being covered in the private and the public market and make sure that those treatments are treated the same as any other healthcare issue, which really essentially we don't want policy that reinforces stigma. We want to recognize addiction as a disease and treat it as such, both in the way we pay for the services and the way we develop them.
Another recommendation is to achieve housing stability. Can you explain the relationship between mental health and having stable housing?
You know, the task force heard everywhere that it went that housing stability was key to mental wellness and to really ensuring that people can live into recovery. It's also one of the biggest challenges to achieving recovery. You know, when people are experiencing mental illness, they are experiencing disruption in their personal lives. They may go in and out of treatment, so it's difficult to attain stable housing. When they come out of treatment, they may require additional supports to live successfully in the community. So medication management or help getting to different appointments or just support in living skills and being successful at sustaining life in the community. So achieving stable housing and achieving housing with supports is really critical. It's a critical part of the mental health system that sometimes gets not included in the conversation. So the task force made it a priority to include it as a recommendation.
Well, and just having that stable housing, then that would go towards the continuity of care.
Absolutely.
Yeah. The state is facing a projected worker shortage, and caring for people with mental health issues is demanding work. What steps can the state take to make sure that we have the workforce into the future facing the possible shortage of workers?
That's a great question, and all of these recommendations hinge on a workforce to implement them. And so it really is a collaboration between multiple state agencies and educational institutions and providers to make sure that we're both recruiting providers into the system, ensuring that we are, reimbursing mental health services at a rate that is attractive to people to want to come into the system and work there. And then also that we're retaining those folks, that people who get trained in Minnesota stay in Minnesota, and that they see a clear career path. So they come in to, as a clinical trainee and see a clear path into psychiatry or another another area of the field that resonates with them. But it really is recruitment, training, retention.
Ms. Wilson, I want to thank you so much for your time today.
Absolutely, thank you.